it's going to be such an empowering chat. I remember watching that TAD. It was just really, really empowering and
It was, yeah.
heartwarming to hear such a very important discussion. Last week we talked to the menopause mothers group, and that was a very important chat. And this week we have you guys, which is absolutely amazing. Obviously, Diabetes Chat is a peer support community run by peers, and we welcome amazing guest speakers like yourselves on to share your expertise and knowledge and experience. And if anyone needs to talk to their diabetes team on any matter in relation to diabetes, please do it. Or in particular tonight, talking about TIDE. So please speak to your diabetes team. They will be there to support you. And I'll hand over to you guys.
Thanks. Oh, Tom, you nicked my first bit. That was literally, now you throw me.
Do it again. Do it again.
No,
no,
I'm not.
Do it again,
Not
because I had the wrong slide up on YouTube. So, I don't know what's going on with my brain today.
It's all good. It's all good. Yeah. So tonight, we're going to be talking about type 1 disordered eating disorders, and we have 2 Sarahs with us. So what I'm going to do first, rather than follow the kind of normal format, I'm going to let you guys introduce yourselves and tell us a little bit about your connection to the chat today and to diabetes. So Sarah L or Sarah A, which one of you would like to go first?
Sarah L, you go first.
Oh, thank you. So yeah, some of you might know me from TAD. I was speaking there with Ellie and Sarah A. I'm nearly 61. I'm a mum of 2 wonderful boys. Apart from that, I'm pretty unremarkable. I'm spent many years in the corporate world and then turned to teaching. I've been a single mum for years and years, although I've finally managed to kick them out. I've been type 1 for about, I don't actually know, 25 years, maybe a bit more. I was misdiagnosed with type 2 to start with. My lovely sister, she's also type 1, and my second cousin is also type 1. So there's obviously something that runs in our family. I'm MDI. I choose to inject because it gives me more control, but we'll probably come on to that a bit later. And I suffer from an eating disorder, which I confessed, is that the right word? Came out, whatever you want to say. It's something that has been with me pretty much my whole life. And I realized that about 2 years ago, it was really time to do something about it. And it was, it was quite a big deal for me to come out and actually admit that I had a problem. So that's me, that's my connection. I love this community. It's so amazing. And you guys have really helped me on my journey over the last 2 years, trying to, get better. And I will apologize now because it's quite an emotive subject. You talk about a lot of personal stuff when you talk about eating disorders. And so, yeah, I'm going to try and hold it together. But that's me. Pretty unremarkable, but really happy to be here.
Sarah, can I just add? I think you are remarkable.
Absolutely.
Don't you agree, Kez?
Absolutely.
I think we all are remarkable. We all have unique stories. And can I just take the opportunity to say, whether it's you, Sarah L, Sarah A, or anyone in the room tonight, if you need to take a break or jump off the space at any time, take care of yourselves. Tonight's chat is about hearing the lived experience and expertise. But if either Sarah or Kez or whoever, please look after yourself, okay?
Oh. So I'm Sarah A. I'm a healthcare professional. I was really lucky to work with Sarah L and someone else called Ellie, leading up to the last TAD, talking about diabetes, where we did an interview together, and it was really precious to hear their stories and really, really helpful to hear their perspectives on things, because so I work from the sort of like clinician side. I work as a originally as a diabetes dietitian, and I started out kind of working in type 1 diabetes and disordered eating when I was living down in Bournemouth. So some of you might have known that NHS England funded 2 places to start with to sort of set up some joint services between diabetes and eating disorders. And one of them was down in Bournemouth, where I lived and worked. And one of them was at King's in London. And so I sort of started working in the field in about 2018. And then when I moved up to London, I kind of just really felt quite impassioned by the work I'd been doing down in Bournemouth. Really felt that it was making a difference for people. In fact, the reason why Bournemouth started out is because somebody that worked in the eating disorders service down there realised that the way that we were managing this kind of these struggles that people were having with disordered eating and you know, struggles around taking insulin and struggles with body image and struggles with weight, the way we were managing that wasn't really going very well. It wasn't really right for the way that the way that some people needed support. And so she reached out to NHS England, reached out to Bournemouth Hospital sort of diabetes team, and they forged this kind of amazing joint service, which a lot of people that I've known under the service have really been very very glad to have been able to access. And so when I moved up to London, I joined Bart's Hospital and talked to the consultants there about setting up a similar service. And so it's sort of been quite a few years trying to get some funding and forming a relationship with the eating disorder service. And we finally got some funding through, but it's been quite a journey, really, because I think it's it kind of is something that's been quite hidden, but that we've been unaware of in diabetes services for quite some time. And actually, quite a number of people, it's amazing how many people I speak to that say, actually, this really affects me, what you're talking about. And so I think that diabetes services and eating disorder services across the country just need to have a better awareness of this. So part of my role is actually in advocating. I'm sure we'll talk about this a bit more. I don't want to steal Gez's thunder if she's going to ask some questions around this. So I won't talk about any of it. But just to finish off with my role, basically I'm doing a PhD in type 1 diabetes and disordered eating around a screening tool, which I could tell you a bit more about later, about conversations between people with diabetes and healthcare professionals to help make them a bit easier sometimes. And yes, that's me.
Well, no, that's great. Thank you both so much for coming to chat with us all tonight. I do. There are a few questions, but obviously people might jump up onto the panel to ask questions, or they might put questions out in the kind of comments, which might come through to us. So we'll make a start, but we'll see kind of what comes through. And if anyone needs to take a break, that is absolutely fine. It's an emotional thing to talk about. It really is, because it does impact a lot of people. And not everyone's aware of it. So, okay, I think if we start right at the beginning, so for anyone who's listening who might not know, what TIDE is, how would you explain that to someone?
I think, well, TIDE is an eating disorder that's linked to people that have type 1, but it's so much more complex than just an eating disorder. There are so many factors that affect you as a patient. Triggers can be body image, mental health, burnout through diabetes management, fear of insulin and causing weight gain. So I think it's much more complex than if there is such a thing as a bog standard regular eating disorder, because it's not just about wanting to be slim or about your body image. There are so many other issues that affect this. And actually, I think the onset of most eating disorders are typically in adolescence and early adulthood. And that can be a time when type 1s get their first diagnosis. And that's something that, I want to pick up later on about trying to prevent people from developing eating disorders. But yeah, it is just much more complex than just an ordinary eating disorder. I mean, our whole life as a type 1 is governed by food labels and carb counting and food portions and weight.
Numbers.
And I think it drives that dysfunctional
Yeah.
relationship with food right from the
Absolutely.
beginning, doesn't it?
And there's not currently a diagnostic criteria. So most eating disorders will have something in called DSM-5 or ICD-11. Those are kind of the way that eating disorders are kind of categorized or understood internationally. And then the eating disorders that we sort of see in type 1 diabetes don't yet have that international consensus, which makes it tricky to diagnose for people, to actually identify. So part of the role that I do is actually sort of teaching services to understand some of those signs and symptoms and to ask people the right questions around it. But some of the kind of things that you might see in yourself or in a sort of other someone else you're worried about might be people that don't take their insulin as often as they had planned to, or sort of have in their kind of schedule for taking insulin, or it might be around food. It might be a kind of quite dysregulated eating, or perhaps quite restrictive eating, perhaps cutting out a whole food group, or exercising to the point where it has quite a cost to it, quite driven exercise. I see some people who might sometimes purge in different ways. For example, taking laxatives or taking other medications that cause them to lose weight that aren't prescribed for them. We also might see somebody over binging, sort of overeating, and sometimes that will be to raise blood glucose levels. So kind of a whole range, and it's often very different in different people. I'm sure lots of you'll be listening and thinking, I don't do that, and that. It's everyone is very different. Everyone's got their sort of their own struggles, but I think the underlying thing that we always look for in this is this kind of underlined by a desire to lose weight? Is it underlined by that something around body image? Because some people don't take insulin, or because of other reasons. Some people are just really burnt out with having diabetes, and that's not an eating disorder. So if somebody refers you to an eating disorder service, and actually it's just that you're really fed up with having diabetes and aren't taking insulin when you meant to, when you were planning to, that's the wrong reason to be referred to an eating disorder service, and that's not the right kind of support for you. So, and then some people might not take, I've seen some people that don't eat carbohydrate at all, and rather than that being an eating disorder, that might be their personal health choice, or it might be that they actually think that when you eat more carbohydrate, that means more insulin, and they've got this association between more insulin being bad for you because of something someone said to them. So they're sort of a bit anxious about insulin being something that's dangerous, or so there's sort of, sometimes it's more around other reasons, education and things. So it can be confused very commonly with other things, and it can be something that requires unpicking.
Yeah, actually, the term diabulimia is something that I find confusing, because it almost suggests that this eating disorder connected with type 1 is just about binging and purging, which bulimia is. I think TIDE is a much better term for it, actually, and definitely something that I think we should be promoting more rather than diabulimia.
Yeah, that's interesting. I think, there's a real drive at the moment to have this consensus on what it is and the different types of TIDE. There's a thought at the moment that there's potentially more than one presentation. And so it's just, not necessarily a spectrum, but like a kind of different people are experiencing this in different ways. And that's really valid, and actually requires support, specialized support, just for individuals. Kez, how did we do?
Yeah, no, it really makes me think about it, because one of and I suppose this comes into when we start talking about a bit later on about what current supports are there, etc. But one of the issues that I certainly faced when I was struggling, a bit like Sarah L said, you know, the access to all of that information, all the labels, all the numbers, all the text showing me my numbers, my diagnosis and misdiagnosis, all led to an issue with how I viewed food. And I think the difficulty that I had was the GP referred me on to a local eating disorder service who went, you don't fit our criteria.
Yeah, and that's quite a rejection, isn't it? I think
Mm.
it's very difficult because eating disorder services have often got really strict criteria because they don't have enough like resources to support everybody with disordered eating of different kinds. So a lot of them in England only focus on anorexia,
Yeah.
and sometimes one other eating disorder, but not all, not the whole spectrum. So yeah, that's one of the issues that they've had kind of we've had across the UK, and I know in other countries as well. But it's not really on, is it? We need support people.
Definitely.
Yeah, I've had a couple of not so good treatment pathways with regular eating disorder clinics, and I won't criticize the healthcare professionals because they were just doing their job, but it definitely didn't help me at all. In fact, the last one, I just discharged myself on the last attempt, because they were focusing on mainly anorexia. And when you even sat in the waiting room of these eating disorder clinics, they're mainly young, very thin girls, and I sat there feeling like a fraud. And in fact, if I ever got chatting to anybody, I'd pretend to be the parent of somebody that was getting treatment, because I didn't look anything like them. I was, average weight. My BMI is, it's low. It's probably too low now, but you wouldn't look at me and think, oh, look at her, she's got an eating disorder. I didn't present as the classic anorexic. And I'm not sure that they really knew what to do with me. The CBT that I had sort of focused on my life as a child, and they tried to pin my eating disorder on the fact that my mother called me a fat baby, and there was never any mention of insulin usage, which was generally my problem. It was severe food restriction and emitting insulin, and it wasn't their fault. I think it was largely because they just didn't have the training, because I didn't present as the kind of case that they would see on a day-to-day basis, because as you've said before, it's a much more complex disorder. It's not just about food restriction or body image or binging or purging. It's so much more complex. So unfortunately for me, the 2 treatment attempts I've had in the past haven't worked. I had been referred again, so I'm going to go back for a 3rd time and see. But again, I'm not in an area where I can get access to some of these tied pilot clinics. So I'm really, really hopeful that we're going to get funding and we can roll out more of these specialist clinics to help people like us.
You raised such a good point, Sarah, that, actually we often have an idea in our heads of what an eating disorder looks like, both, people, the general public and healthcare professionals. And one thing that we learned from these kind of joint clinics was that very often people weren't underweight, and yet had quite, for people that had decided to kind of not take very much of their insulin in order to lose weight, they kind of had this quite high risk, as we all know, sort of not taking insulin, more like to go into hospital with DKA admissions and be quite unwell. And we were seeing people who were really, really, really poorly, but that wasn't always recognised by the eating disorder service because people weren't low weight. And so one of the things we've been working on trying to get into people's kind of criteria is around understanding that weight doesn't really play a part in this at all. It's nothing to do with people's weight. It's to do with the diabetes and the insulin and and risk of starvation through not having insulin and those sorts of things. So I hope this is all right to talk with everybody, but do kind of chime in or sort of pause if anyone finds that difficult for me to mention sort of risks in any kind of very blunt way. But one of the things that we deal with is people can be really, really, really unwell, and what's been great in North East London and North Central London is starting to build that relationship with the eating disorder service, despite the fact we don't have any funding. And there are more and more services that are starting to do this. So in Cambridge and South Wales, lots of places, Chester, lots of places across the country. I'm having more and more conversations with teams that are starting to build these links. And so one of the ways in which I work with the eating disorder service is sometimes we just overlap our appointments, so that we kind of have some shared understanding of what it is someone's going through, and they can advocate for themselves or actually we can advocate for them as well, because sometimes it's really difficult, isn't it, to be working with two different services that just don't speak to each other. So to have people do some of that work for you and to actually talk to one another must be such a relief. So I think there are lots of kind of more soft approaches, like for example, I'll go to their clinical meetings, so they're really, really busy, so I'll go to an eating disorders clinical meeting, and I'll kind of ask them questions to try and learn, how would you approach this situation, or sometimes I'll use it as a way to drop some teaching in and be like, this is really important for you to know about diabetes, and just kind of and actually there are some amazing eating disorder services who are leading on this across the country rather than the diabetes service, which I think is really encouraging. So more and more awareness. But yeah, I think it's important to have supervision between the professions, and that's something that I've been working on is having a monthly supervision. We've got this national supervision network now, and I just invite if you've ever got a healthcare professional you're talking to that needs a bit of support with it, then just say, have you heard about this supervision group? They can come and kind of talk and ask questions about it. And
yeah, that sounds good. Actually, that sounds really good.
You actually made a really important point there about people that don't present as somebody who you might think has an eating disorder. And so, for example, I would go along to my diabetes clinic, and my HbA1c was great. My weight was okay. My BMI was okay. But as far as my numbers went, they were great. So it was essentially, there you go, Sarah, have a gold star. We'll see you next year. You're a fantastic type 1 diabetic who is obviously managing herself brilliantly. You're super healthy. And I am so not healthy. I can barely function on a day-to-day level sometimes because I have nothing on board. And I think it's not just the eating disorder clinic that need more training and more information, but also the diabetes clinic.
Absolutely. I think we really need to get better at that. The number of people that have that, the discipline, the cost it takes to keep numbers within that sort of gold standard range, and for some people it can we've heard, a lot of you will have heard of the term diabetes distress and burnout, and but when you have disordered eating or an eating disorder, and there's this real drive to kind of keep the numbers perfect, either because of wanting to lose weight or because of wanting to lose weight and maybe to keep the numbers within that range as well, or so the weight loss side, it might be around obviously people taking very careful amounts of insulin, but they might be really restricting their food in order to lose the weight. And it can have quite an impact, can't it, to be restricting at that level. It can be exhausting. You can get all of the signs of not having enough food, of malnutrition. It can affect our thinking, when we're trying to work. It can affect our mood. So when people don't have very much glucose on board because they've not been eating, they can be lower in mood. They can sometimes might not have as many reserves of glucose stores in their liver, so glycogen, if you've heard of that before. So might be more prone to having hypos. And in some people that I see who have not been eating very much, I also find they might have more severe hypos, or hypo unawareness, if you've heard of that, so where you're having hypos but you don't feel low.
Mm-hmm.
And so all of those sorts of things can happen, and that has a real impact on day to day, doesn't it? Like, it can be really frustrating, really stressful. And actually, quickly on that note, if anybody is experiencing that sort of thing, just to say that if you've not been having very much carbohydrate, if you use a glucagon pen, sometimes it doesn't work if you don't have very much glucose on board, like glycogen stores on board in your liver. So just a suggestion to use a different hypo treatment if that's the case, because it might not work. So yeah, but so it is something that we often miss as diabetes professionals. We often miss the disordered eating. We can even exacerbate that sort of distress that people are having by really kind of digging down even deeper into the numbers, even when they're already trying to be as perfect as possible. And I think that's a mistake. We need to kind of be looking out for that with people and asking those questions. What is it taking for you to keep the numbers in, between those levels? How are you feeling about your weight? Sorry?
Absolutely, totally agree.
Yeah, I mean, this new time and tight range for me is just horrific, because I float just at the level where nobody's going to say you've got a problem, because I don't want people to know I've got a problem. But now they're talking about time and tight range. There's no way I can do that, even by restricting my food. If I've got no insulin on board, I just can't do it. So that to me is like awful. I hate talking about it. When people say, "Oh, I've achieved this," I'm just happy to just keep floating, so that I don't get hauled in and they say you're not looking after yourself, because I don't want them to know. It's that secrecy, isn't it, of not wanting people to know that you're not actually managing yourself particularly well.
I think one of the things that is kind of tricky as well is if we are really struggling but seeing different people at every appointment, or perhaps not having regular follow-up. Let's say clinic appointments are cancelled by the service a couple of times, so you actually go without seeing anybody for quite some time. Or maybe communication lines aren't very good, like in order to get hold of the diabetes service, there's an inbox you can contact, but they might not get back to you for a week or something. And it just seems to fall into a black hole. And when you see a professional, like, they're in a rush, they're running late, so these are some of the things that we're thinking of is, okay, actually, how do we make the environment a bit better? How do we give more, how do we make it a place of safety, a place of reassurance, that people feel that they can actually open up about what's going on? And I think one of the things that we can work on is trying to have a familiar face in clinic. I don't know if you've ever had that before, like a kind of somebody that you see a bit more regularly, that you actually kind of get on well with and feel a bit more comfortable seeing. I mean, it might not be the case.
I think that's a great idea. I see a different person every time I go, and the first thing they do is they weigh me, which is awful, because that's the last thing I want. So I think that would be a great idea.
You can absolutely say no. Sorry,
No, go on.
Jumping in, but you can absolutely say no to being weighed. Just to say, do say no, thank you, if you don't want to.
Yeah, but then it sends a red flag, doesn't it? Almost.
I can understand what you're saying, yeah, but I think it's maybe it's something that we're actually working on, sort of trying to spread the message. Don't automatically weigh people before going into. But you could have that message. You could have that discussion with people outside of that appointment. Maybe sort of email in between and say, I just don't feel that comfortable with it. Could you just put something on my notes not to weigh me? And hopefully they should see that. But yeah, I think everybody should have the right to be able to say, like, turn down a test. You don't have to get it done.
Yeah, definitely. I think it's I'd say in the last, I'm trying to think how many appointments it is now, 3, so maybe a year and a half actually. I've seen the same nurse and consultant, which has been really helpful, because in all of my appointments prior to that I would cry and no one would ask me why. But it's harder to kind of hide that if, like, you're seeing the same person and then they're suddenly like, why do you keep crying? Like, what is that about? But yeah, it's I think it
So
would
you feel
be
more
useful.
more able to open up now because you're seeing people that are familiar to you.
Yeah, definitely.
Good.
Um,
I mean, it's difficult to kind of. I say that this is something we'd like to do. I'm sure that every service would like to do it, but it depends on their capacity and on sickness and things like that. But I think hopefully, you know, I suppose I don't want to put this on anyone here. You know, because I think sometimes it's difficult to carry that mental load, isn't it? If I'm already struggling and now I've got to kind of take on this decision to deal with this myself. But I would encourage you, if you do feel able to bring up that discussion with your team, if this is something you're struggling with around disordered eating, or any sort of distress around managing the diabetes, if it's affecting your mental health, talking about things that will help, because sometimes it's ever so helpful for us if people say, this is what I think will help me, and then we can work with you to make that something that's a bit more regular, hopefully.
Yeah, that makes sense. I guess that kind of leading on from that, so we've talked a little bit about, I mean, type 1 in general is stressful, let's be honest, and it has an impact on your mental health, your well-being, all of those things. But what sorts of indicators or patterns or things would either of you consider to be more kind of problematic? I don't know if that makes sense. If I'm not making sense, then just ask, but I'm hoping you might kind of.
Sarah, do you want to go first? Maybe that might be interesting to hear.
Yeah, I can just talk about my own experience, really. And you're absolutely right about the mental health. I think quite a lot of us don't have any extra capacity to deal with, you know, other stuff, because our minds are already full of living with type 1 and having to manage it, and you just get something else that arrives on your lap, and it just ends up being too much in your life. And for me, that's food. I've always had issues with food. I've always had a problem, and although it isn't on my medical record, it should definitely be part of the diagnosis process, because your weight is going to be affected generally. You know, before you're diagnosed with type 1, you're generally very thin for all the reasons we know about. And for me personally, on my diagnosis, it would have really helped me if somebody had said, and actually, you're going to put weight on for this reason and this reason. But nothing was said. And in fact, my original diagnosis was type 2, which is very strange because I was very thin, and you know, I was given metformin and glycoside and sent away, and of course I didn't take either of them. I just carried on, and I was actually first diagnosed in France, which was tricky because there was the language issue, and I didn't really understand some of the finer details about being diagnosed as a type 1. And it's crazy because my sister's type 1, so they should have picked it up, but it wasn't picked up. And eventually they just gave me a sheet and said, eat that and inject that. And that was it, because I couldn't really comprehend or understand what this meant in my life. And I put on a massive amount of weight and had 2 children in 20 months. And it was a huge deal in my life, living in a foreign country, not really having any family support, newly diagnosed, 2 young children. And my marriage failed because, I think, partly because I put all this weight on. And it was just very hard to admit that I had a problem. So I went to TAD, and I was standing in the line looking at the lunch thinking, what on earth am I going to have? And Partha was standing in front of me, and I said, excuse me, I said, I think this has been amazing today, but it would be really great if we could talk about some other issues which are not quite so inspirational and wonderful, like eating disorders. And he said, that's a great idea, but nobody wants to talk about it. And I said, well, I will. And it was at that moment I realized I had to kind of come out and admit that I had a problem. So food has been a massive part of my issue, and I think type 1 has just made it 100 times worse for me. And I'm hoping that this next round of treatment will help, but I just don't know if it's going to work. I just don't know, because for me, treatment equals
Yeah.
weight gain, and that's what I struggle with. So I'm not even sure if I answered your question.
I think you did. It's like, yeah, I think you're right, because I'd say a similar thing. You know, there wasn't that discussion about. I mean, similarly to you, I was misdiagnosed type 2 first, and after my correct diagnosis, put on a lot of weight, and I think there'd always been those background struggles with food. I guess it's, yeah, I think it's like Sarah A said, you know, feeling, you know, others feeling confident to have those conversations with us, because we're not always going to be able to or want to say that we're struggling, or we might not look like we're struggling. So yeah, it's
It is interesting, especially with Wes Streeting saying today that, you know, he wants to focus on prevention rather than treatment. And at the point of diagnosis, I mean, it's mainly adolescents, mainly young people who are diagnosed as type 1. That's when they will catch it. And particularly amongst young females, I think part of that diagnosis process should be talking about what might happen to you in terms of body image and body shape changing and weight gain and all of those other things, because eating disorders are more prevalent amongst young adolescent girls than anybody else. So that would be a good way to prevent something, you know, somebody developing an eating disorder from the type 1 diagnosis. I mean, I know I already had an issue, but yeah.
One of the, just thinking about treatment quickly, I know the question to go back to is around sort of signs and symptoms, but so around the treatment, I think one of the things that's really missing from a lot of diabetes services is a diabetes psychologist. In under 18 services, about 50% of services have a diabetes psychologist, but you know, in adult services it's much more rare. And so we don't, you know, if we don't have a mental health professional within the team, not only does it mean that we don't have mental health appointments we can offer from within the team around diabetes related struggles, but also that person can really help to upskill the team that they're working with, and to understand what they're looking out for, to help guide conversations. I mean, I have 3 psychologists that I work with and a psychiatrist within my diabetes service. It's incredible. We're very lucky. But what that means is that we have like training, you know, every other week for the team to understand mental health better. So I think that's one thing that you know, when we get hopefully some more funding through for Tide nationally, we need to think about those mental health professionals being embedded into diabetes services, as well as those links with eating disorder services. And that's not just around eating disorders, is it? That's also around all the other things that people can experience in relation to diabetes, like depression, like anxiety, you know, and the other things that we experience as humans as well. So there's that. And then just around the signs and symptoms quickly. So we would be looking out for things like, so if somebody's got the slightly more classic TIDE or diabulimia, or, you know, if those, the one that you might have seen a bit in the media around people that sometimes don't take their insulin to lose weight, we're more likely to see people with a high HbA1c or high blood glucose levels. So some people will keep them high quite a lot of the time. It takes a huge amount of discipline for some people to keep them that raised. So it might be quite an exhausting task to keep them that high, and require a lot of different sort of tasks and behaviours to keep it that high, not just to kind of not taking the insulin, but or sometimes we might see quite erratic, quite very, very up and down blood glucose levels. So for example, somebody their blood sugar running quite high, but then where they've sort of given an unspecified sort of a large amount of insulin, had a great big drop in a hypo, and there can kind of be, you know, sometimes like a rescue dose or something. And so we can sometimes see very sort of big ups and downs, and that's just I think a sign that people are in distress and struggling. And so that's one of the things we might look out for. And another thing is people being admitted. So you can imagine people's blood sugars are high a lot, and they also have a lot of ketones a lot of the time. Some people seem to be, something we're researching is like they might become metabolically compensated, we call it, where like normally if we have a small amount of ketones over 0.6, over, you know, or kind of a high amount over over 3.0, some people, most people will start to feel really unwell and will have lots of symptoms around that. But people that are there a lot might start to kind of get used to that, and so be running high a lot. And the problem with that is that if they suddenly get the flu or something, or get, you know, get gastroenteritis, it's sailing a bit too close to the wind, you know, to the edge. It's sort of just falls straight into DKA very quickly, and so we get some very sudden DKAs in some people that I see, and they can become unwell really quickly. So I think that's something that we look out for, is if somebody goes into hospital with DKA, one of the things that we can miss a bit in medical services in the NHS is follow up after someone's had an admission. You know, it has been common for people to go in, be seen by the medical team, have insulin, you know, be given insulin, and then be discharged. And actually the diabetes team finds out afterwards. And what we really need is, when people go into hospital, for there to be connection with the people that they know, like to see those familiar faces, to have support from people that you're able to talk to stuff, you know, about stuff with. And also if there's a plan. So Sarah, you were talking about well, what's going to happen if I get treatment? You know, how am I going to be able to tolerate this because I'm going to put weight on? I'm really worried about this. And you know, we often have plans that are very different to what would happen in A&E or like in standard diabetes treatment. So we would have often like a kind of staged, like, or stepped reintroduction, or we might have a particular, we call it a DKA protocol. So it's like where somebody has a lot of ketones on board, you know, they've got some problems with their bloods because of that, they're not very well, and we have a usual way of treating that, but we might do that differently for somebody that can't tolerate a lot of insulin quickly because they just like psychologically really struggle with that. So we might we might have a kind of individual plan that we've agreed with the person with lived experience of diabetes, and with the doctor or with the dietitian, you know, with this prescriber, whoever it is, and we'll have something different. So basically, if you are experiencing any of that, kind of any of these symptoms, and you're worried about admissions and what that would mean for you if you went into hospital, this is something that we're working on, is actually trying to make hospital stays a bit more pleasant for people, and actually to have a bit more of an individual plan for people. And then, do stop me if I'm going on for too long, by the way.
No, you're okay. That's fine.
And then
Actually, I had a quick question for you. I don't want to jump around. A question for Sarah A. Just, I know that one of the things that was flagged up in the parliamentary inquiry was that there wasn't really a recognised diagnostic criteria yet for this problem. And I wondered if you knew how far, has anything been done? Is anybody pulling something together? Do you know whether anything has been actioned on that point?
Yeah, it's a good point. So things like DSM-5 and ICD-11, those kind of eating disorders categorizations that I just told you about, they often get updated every sort of 10 to 15 years or something, from what I understand. It takes a while. So when you actually look at what's being published recently, there have been some recent publications on what people think the diagnostic criteria should be. So we've got, for example, the Royal College of Psychiatrists, I think you know about this one, Sarah, produced a guideline called MEED, Medical Emergencies and Eating Disorders. It was what replaced the marzipan guidance, which is medically what we used to use for eating disorders. And now there's a whole chapter on diabetes, which is really helpful. It's come out of these different services that have been working jointly between diabetes and eating disorders, the TIDE sites. And it's got kind of a proposed, like a working diagnostic criteria in there. And then we've also got King's have recently published their own criteria for that kind of classic tired I've just been talking about, that sort of, I'm sorry I've given it my own label because it's how I sort it out in my head, but it's that kind of, the one that we've often thought of when we've talked about diabulimia, is it's sort of when people are really struggling to take insulin and have higher blood sugars and higher ketones and are more likely to go into hospital with DKA. So you know, that's the one that King's have kind of been focusing on a bit more. So I know also that Theresa May and Sir George Howarth have been really pushing NHS England and or working with them, I think, to actually kind of continue to push that agenda around getting that diagnostic criteria among some other targets that we have nationally for TIDE. So it's still high on the agenda. And it's not just an international consensus for the diagnostic criteria, but it's also things like having guidelines in NICE. Have you heard of NICE before? Like that National Institute for Clinical Excellence, I think it's called. And it's sort of, sorry to patronise anyone that was just listening and I just said, you know, NICE, of course you do. But it's just it's kind of the national guidelines for medicine and for healthcare, and so we really want eating disorders to be part of the diabetes guidance, and so that's what we're really pushing for at the moment, and that's something that the parliamentary inquiry has been saying they want to. So yeah, do you want me to stop going through the signs and symptoms? Should we talk about the inquiry? What would be better?
Yeah, I think I was going to ask just before we did the inquiry, just briefly, kind of. So what does a treatment pathway look like at the moment, I guess, is the question.
I think that depends on where you live, if I'm being really
Yeah.
honest, unfortunately. Yeah.
So what we'd look for at Barts is what the kind of individual struggles were that people were having. So Sarah, what you were talking about with maybe kind of eating a little bit less and keeping your numbers down. For example, what we might start out with is a conversation with a member of the team that you're getting well with, or the dietitian. We might look at having a joint appointment between the psychologist, if there is one in the team, and a diabetes professional. And then if actually we felt that there was sufficient reason to think that an eating disorders referral would be helpful, then we'd make that referral. And then, of course, across the country, everyone has different diagnostic criteria disorders. So in a case where they didn't accept the referral, I would encourage services to look at joining up in other ways. So having case discussions works quite well. So having like if somebody is, if I, for example, was seeing someone regularly with kind of a more restrictive eating disorder, then I might meet up with someone who would supervise me for eating disorders, because I could talk through what the priorities are, like how to approach conversations, even things like, do I weigh somebody in clinic or not? And to talk through and give them a perspective of the diabetes as well, which would be really helpful. Then if they are accepted into an eating disorder service, let's say a lot of the time people will use CBTE, so cognitive behavioural therapy, that's specifically designed for eating disorders, but that does not take diabetes into account normally, which is a really important part of treatment, particularly for people that aren't taking their insulin. Because if you're trying to follow a model of an eating disorders treatment plan within eating disorders, it's often focused around weight restoration and a meal plan and food, reintroducing food, which for some people is
absolutely
not appropriate. Some people, they're eating enough, they're not taking their insulin, so it's totally inappropriate for them to follow that kind of plan. So the eating disorder service would hopefully have a way of tailoring that CBTE program, and normally CBTE would be given in 20 sessions at a time from, I think, most services. If there's any eating disorders services out there listening and, you know, they do differently, then I know that may well be the case, but I think most services usually would do 20 sessions and review, and that would often be with a psychologist or a cognitive behavioural therapist or with an eating disorders practitioner. he might be a mental health nurse by background or someone else. So it really depends. But the nice thing about being within an eating disorder service is that, theoretically, is that they have this really close team working. So usually most services will meet every single day to talk about the people that they see, in a positive way, to kind of think, well, how can we work best for the people that we see? So they have this like incredible supervision between themselves, which we don't always have as much in diabetes, because we have like enormous caseloads of thousands of people. So we don't have the opportunity to meet up every day and talk about everybody, but we do meet often every week or several times a month to talk about the people that we need to discuss, or like a kind of a priority for us individually. But yeah, so that's one of the nice things about eating disorder services. So I do think there's a big role for eating disorder services to be able to do some therapy with people, and alongside the diabetes service. So that's ideally where that treatment should be, is from the eating disorder service.
I think the service that you're offering is different to quite a lot of other treatment pathways around the country, and there must be other people like me who have problems, who go to seek treatment, and the treatment just for whatever reason isn't right for a type 1.
Yeah.
When on my first attempt, they assigned me a dietitian, and the dietitian, to start with, that was before the CBT started, and the dietitian said to me, it doesn't matter what you eat, as long as you eat 5 times a day. You can have chocolate for breakfast if you want. And that's just against everything. Being a type 1, you would not eat chocolate for breakfast, especially if you're restricting your insulin. So I think it is like a lot of healthcare around the country. It is a bit of a lottery still. And one thing that does worry me is if there are other people, other type 1s that have eating disorders, and they are referred, it is potluck as to what kind of treatment you get. And I'm not criticizing anybody here. It's just, we just need more training. And what you've been talking about, Sarah, all those processes and treatment pathways, it needs to be filtered down to all these other eating disorder clinics, because they don't have the specialism. They don't understand what it's like to be a type 1. And I'm just speaking from a patient perspective, because I've tried twice now and it didn't work. I'm going to go back for round 3 and see. So I think it is just potluck, unfortunately.
It has. I mean, where I live, it took I don't know, 3 years or something to get to the point where we started to do joint appointments. So I think hope it sounds. I mean, I'd love to come in and sort that out for you. But the obviously I don't work in your area, but I think that if when you persevere, sometimes it can get better. And when we heard from Ellie, when we've heard from I know lots of people across the country who have had treatment for TIDE and recovered, and often they've gone more than once. And then it's actually when things have changed because of some training in the service, or because new services come in to support, something like that's changed their experience of treatment. So I would encourage you to persevere with it. And I'm also, if it would help, happy to give you some all sorts of resources and things and ideas for how to point the eating disorder service towards diabetes, better understanding of diabetes. I know you could do that too, but there's specific healthcare professional competency like CPD out there. So or even videos, all sorts of things they could watch, things, there's e-learning programs they could do. There's there's the peer supervision network I was telling you about. There's a lot of opportunities out there. So and then there's their local diabetes service. So if I were you, I'd probably make it a condition of treatment that I will come, but only if you talk with my diabetes service and we meet up with them. It might be sorry, that's quite a directive, but you know what I mean. Like, you could say, this is something I want you to understand the diabetes side. So this is something maybe one option. What's worked quite well for some people is having the professional from the opposite service coming in for the last 10 minutes of the appointment. So that's what they do at Leicester. They've got a proper funded TIDE service there. and they have the diabetes dietitian, who's very, very experienced. She comes in for the last 10 minutes of each of those CBT sessions. So there's different ways of doing it depending on capacity and people's days of working, but I mean, obviously I'm sort of trying to sort of point people towards the opportunities, because there are I think there are opportunities to do this softly, even without funding, just thinking, you know, how can we actually upskill in this? How can we work together a bit better?
I think you're right. We have to be positive. I do still think, though, that people like me are falling through the cracks, because I'm not. I fall outside of the TIDE pilot schemes, which are around the country. But yes, I don't fit into the same eating disorder criteria that I find people sitting in the waiting room of my local eating disorder clinic. And so I do feel that I am slipping through the cracks somehow, and I'm not getting the best care. And I'm sure there will be other people, you know, as we raise this issue, there'll be more and more people realizing that maybe they have an issue, and they put themselves forward and promote themselves and say, I would really like some treatment. I want to get help on this issue. And for whatever reason, it just doesn't work. So we've just got to keep our fingers crossed and hope that we get more funding and we can roll out more of these TIDE schemes, because what you've just said about, you know, having psychologists and psychotherapists and all these people involved in the process, because the care is very siloed, isn't it? At the moment, it's and that's not just in the TIDE, in the area of TIDE. I think, you know, across the NHS generally, that's the way care is operated. So
yeah, you're right. I think that leads well.
maybe
Okay, you can finish. Sorry. Yep.
Yeah, no, it's just to say that maybe patients like me, people like me, need to take the bull by the horns and be more proactive and do some of the things you've just suggested.
I think it may help when people are able to when they do have a moment where they're able to advocate for themselves and say, hey, you know, I don't, it didn't work well last time doing it like this. Can we think of something different? Could we involve this other person in these conversations somehow? Could we, you know, I really would like you to go away and learn more about hypos, please. Something like that. But not everybody has. We often, a lot of us go through life, you know, often have moments where we can't advocate for ourselves. So, and that's just life, isn't it? So, I think
it's tiring, isn't it? Like, especially if you are doing it multiple times.
Yeah.
And then you're kind of not hitting the brick wall, because I think people do listen, but then nothing comes out of it.
Yeah, something sits in it.
And also some people can't articulate that, you know, they don't have the means to actually articulate what they want, or they don't know where to find information, or they can't access it for whatever reason. So
yeah, and there's obviously there can sometimes be a little bit of secrecy around it too, can't there? Not wanting to open up because it hasn't gone well in the past, or because people have lost some trust with their healthcare team. You know, maybe people offered to do some stuff and they didn't do it. You know, people had too many appointments cancelled, or people haven't followed up on some work, and maybe they're feeling maybe there's probably loads of reasons why people don't feel able to open up about things, but so therefore in that case, you know, that's why it's so important that we do things like this, you know, continue the work of the inquiry, because we need to make sure that we can advocate for those who can't advocate for themselves. And I think this work will continue. I think there's been people have been feeling a bit disheartened that some of the TIDE, you know, the Bournemouth TIDE pilot closed down, because the local commissioners weren't able to fund it longer term, which is a real shame. Most of the other pilots are still running, you know, all the others are still running at the moment. We do need more longer term funding. But I know that, you know, if you look at all of the different organisations that are really they've really bought into this, like JDRF, you know, NHS England, I still have regular conversations with them around funding. You know, there's sort of, I know this is something that's still very high on their agenda. So I think, you know, there's a lot of people out there still, you know, lots of people doing research, you know, applying for funding to kind of get the really important research done around it, because actually that is often what commissioners want is the kind of the data, so that they know, does it work, your service? Is it any good? How many people have Tide? So this is the sort of thing we need, and we do have some really big research trials going on at the moment around it to help us get funding. There's a really big one on prevention at the moment, called Priority. There's one by Professor Chrissy Jones. She's a psychologist, which you might want to look at if you're interested. There's one called Steady, which is around CBT training diabetes nurses and dietitians, so that we get better at sort of the mental health discussions. There's all sorts going on at the moment.
Yeah. I was part of Steady, actually. But yeah, I really like the idea of like the multidisciplinary, everyone getting together and actually communicating. So if anyone wants a social worker, hit me up. I'm there. But yeah, so a couple of times we've mentioned the inquiry. So what can you guys share with us about the inquiry?
Sarah, were you involved in that?
No, I wasn't actually. No, I mean, I've obviously read it, and I know what the key takeaways are of it.
Oh, good. Then you can you can recount them then.
Yeah, I can maybe. Well, I mean, the key ones were to produce a recognised diagnostic criteria, which we talked about, and then because there isn't any approved pathway, any treatment pathway for Tide, and there isn't any real comprehensive information or peer support for people. So those were the key takeaways, and obviously it calls for more research into it. But the key takeaways firstly was to get this criteria, because without that we can't move forward, and that has to be sort of recognised internationally, so people can understand exactly what Tide is. But I think just talking about it like this is raising awareness all the time. I mean, people talk about Tide now, and they know what it is. 2 years ago, they had no idea. So we've done some good, haven't we?
For sure. I looked it up, and it also says about a NICE clinically approved pathway for Tide prevention and treatment. And we nearly got it into NICE. I was actually involved on one of the committees for type 1 a few years back, and nearly got a quality standard 3 for Tide, but it has this quite like high bar for evidence. It needs to be kind of very high quality research, usually, that sort of is used to kind of get things into NICE guidance. So that's why all of this research is going on, partly, but it is actually something we're working on as we speak, is can we get a pathway into NICE? Because once that's in, that changes everything. That can change an awful lot, because it's the gold standard practice then, and then everyone has to pay attention. So that would be a really big thing to be able to do. And then there's something here about having a registry for people with type 1 to help with kind of identification and treatment. So that's not something I can give you a lot of detail on, actually. But I think it's basic. It's along the lines of better record keeping and better. One of the issues that we have in the NHS is that we just have so many different record systems, and there have been so many politicians that have tried to just get us to use one, but there are a number of reasons why that seems to be impossible, and it drives all healthcare professionals mad that we all use different systems, and therefore we don't have each other's notes, we don't have each other's letters. It's one of the things that if you saw the coroner's report that came out from there was a sort of there was sadly like a sort of like a letter that was sent to Parliament after an inquiry into the death of a lady called Megan, who had Tide, and this was before any of the Tide services were available. And she, I met her parents, and they were involved in the inquiry as well. In fact, they are two of the people who have really driven a lot of this work. Amazing people, called Leslie and Neil Davidson, and they and sort of one of the things that came out from this coroner's report was, you know, that she was let down partly because there wasn't a sharing of records and people didn't know what was going on. So that's something that's come out of this inquiry, is we need to be better at sharing, and GDPR doesn't make that very easy. I'm sure that if some of you are teachers and things, you'll have kind of experienced this, that it does make it a little bit harder to kind of share information, sometimes for good reason, but yeah, so that's the other thing that's come out. So I think just focusing on the things that we are actually progressing with, NICE, I think, you know, that's something in the next few years that should be looking very positive. And the diagnostic criteria, it's really high on the agenda, and I do think that will change soon.
I think there are some quick wins though too. For example, at diagnosis, I'd love to know what other people's experiences are of when they were diagnosed. But at the point of diagnosis, that is something that could be talked about and discussed, particularly if the diagnosis is with somebody that you think could be at risk or in a higher risk category, like an adolescent female. My diagnosis process was absolutely appalling. It was just basically, there's your menu sheet. If you eat that, you inject that. It was literally, that's what I was told. So, you know, I don't know. I'd love to know what other people's experiences are of their diagnosis, and whether anybody if it was discussed about eating or disordered eating or any issues that they might have. Was that even brought up as a topic when they were diagnosed? I would think probably not.
No, I mean, I was diagnosed as COVID hit, so that wasn't particularly helpful. So it was even, I don't know if it would have been harder or easier if that hadn't happened. But no, it was fixed doses initially.
Yeah.
So yeah.
Is anybody told that you're going to put on a shed load of weight when you're first diagnosed?
Definitely not.
Because I
No,
definitely wasn't.
Definitely not.
It's tricky because I've met some people that were told, you know, you're going to put on loads of weight when you start taking insulin, and then went, oh gosh, well then I won't take insulin. So then that was actually what it was for them that made them think, you know, that sort of, I think what it is it's making sure people have sorry, I'm not invalidating what you said there, Sarah, at all. I think you're right. There's definitely a lot of people that experience that, not having enough information at the start, and not feeling, and for that horrible sort of shock that can happen when our body changes quite quickly. I think that it can be really uncomfortable for a lot of people when you know, a lot of us know that, like, when we first get diabetes, we can often lose a lot of weight, and this can often happen in those formative years as a child, as an adolescent, as a young adult, where we're learning who we are, how to express ourselves, what our identity is, and then diabetes comes in and potentially weight gain after diagnosis. We take insulin, we restore the weight that we lost. Some people to have some catch-up growth if they were children at the time. And also you can get something called insulin edema, which is where we, if we give insulin to people very, very quickly, a lot of it quickly, they can put water weight on. And that's usually something that only happens in the hospital. And it's when people have a severe deficiency of insulin, because they don't have any on board. Like if people are in DKA, or if they are newly diagnosed, and then give people some insulin, and water weight can come on quite quickly for people. So that can give people a real, like, oh my goodness, my body doesn't feel quite how it did before, and this and it can be quite distressing for some people. But I think that everyone's experience of kind of diagnosis can be different, but what often isn't there is that regular psychological support around diagnosis. You know, how do I feel now that this has happened to me? And I think the other thing, as you say, is that huge focus on numbers. You know, some people do carb counting from diagnosis rather than fixed doses, and they're weighing food, and they're working out their insulin doses, and they're working out what we used to call correction doses. We try and call adjustment doses now, and they are looking at food labels, and they might be being weighed in paediatric clinic every 3 months or even more regularly. And people nowadays with continuous glucose monitors, although they are the most amazing pieces of technology, it has increased the amount of data, hasn't it, that we're looking at. And then you've got the tech, you've got all of the paraphernalia that comes along with having a pump. And you know, even though these things are amazing, sometimes it can add to just, you know, there's a lot to deal with right here. I've got to change my Omnipod every 3 days, and actually I'm getting so many alarms, it's driving me crazy. So I think when you look at that, you actually realize that it does potentially reflect the anorexia, like the eating disorders mindset, checking of calories, weighing food, checking data all the time, weighing myself. So you know, when as healthcare professionals, we know that the kind of traditional way of treating diabetes, of carb counting and insulin dose adjusting, it works. There's loads of research to show that that can be the most flexible and the most effective way for people's blood glucose levels to come down like closer to the range it was before they had the diabetes, and they are at lower risk of any sort of long-term complications because their blood glucose levels are a bit lower. So great, but then that also means that they are actually doing more of these eating disorders type behaviors, which if somebody had an eating disorder before they got diabetes, can re-trigger it for them, or maybe it will bring it on for the first time. And it can be, as we said, quite secretive. It can be quite hidden, and people weren't always feel able to talk about it, and so it can be hidden for a long time for some people, and they're not getting the support that they need.
Sorry, I think I muted myself. I've been a little bit on the fence about asking this question, but I'm going to ask it anyway. In terms of managing eating disorders, if you require kind of more intensive support, is there any reason why somebody who was on a hybrid closed loop would not be able to use that whilst in treatment?
That's a good question. So we're actually we're going to be writing something on this soon for technology and eating disorders. I think so. One of the reasons why somebody might find it easier to be off of a pump is if one of the reasons is around self-harm. So some people I see who are quite unwell might take the pump off or something, and so if there's somebody that actually would just find things a lot easier to have a continuous amount of insulin, let's say from having some background insulin, you know, having a break from the pump, because it takes away that kind of, I suppose, way to self-harm. That's one reason. Another reason is if they've got diabetes distress and the technology is actually making it a bit worse, they might have a little bit of a break from the pump. Some people that go into hospital, I mean, we try to support people on the pump, but sometimes when you go into hospital, sometimes they put you onto a different, like an infusion of insulin, so you might come off of the pump for a period then. But to be quite honest, I know I'm saying things that are quite rare. A lot of people that we have on, you know, we see a lot of people do go on to hybrid closed loop systems because it can take away some of the work, can't it? You know, it can also, if actually giving insulin is something that's a bit distressing for people, it does some of the tasks for you. It can be a tricky one for some people to tolerate, though, having something else give the insulin for them. So if they're very controlled with how much insulin they give, then having having something else take on that responsibility for them can be something that's quite hard to do straight away. So but quite a high number of people with eating disorders that I see do eventually, as they progress through treatment and as they recover, go onto a pump, because it's just so useful, isn't it? And it can improve people's lives. So that is something that we work towards, is supporting them to be able to access all forms of treatment.
That's good to know. So just kind of finishing off then, guys, for both of you, what would you say your hopes are for the future, for yourself, for awareness, for the community? What would you like to see happen, you know, in the next couple, 5, 10 years, whatever? What would you like to see happening?
I'd like to still be here and with my boys, and that's one of the reasons why I decided to do something about it, because I knew I was struggling to function on a day-to-day level. So for me, on a personal journey, it's just to be able to see my boys grow up even more. And if we can raise awareness, any awareness, if anybody on this call or any friends of people on this call think they might have a problem, is to really encourage them to go and try and seek help and not keep it a secret like I have for years and years, because that doesn't do you any good whatsoever. So if you think you've got any kind of issue with food, try and seek some help from somewhere. And that's all I would like to say. And that's one of the reasons why I really wanted to speak out on this issue, because I don't want people to be like me, 61, struggling to walk up the stairs because I have no energy. So yeah, that's it really.
Thank you, Sarah. I think that I would feel really encouraged to see, you know, an even bigger sort of a thriving community of people who have, who are able to share their experiences of having TIDE and have kind of access treatment and have gone on to live really full lives, and you know, to be able to say that they're recovered, but to be there for people who are experiencing this. I mean, obviously the hope is that we'll have a treatment for type 1 and that it will no longer exist. That is the plan. But you know, if we do still have type 1, then then I think my hope is that we'll just have as I say, a big community that people can access for support, because I think at the moment there are people who are advocating for this, but you know, we're sort of slowly linking people up and slowly advocating together. I think having politicians have this, having had this at the top of their agenda for some time, they've made some really big changes when it comes to funding and guidance around TIDE. So having funded services in every region in the UK would be obviously is what we're aiming for. And I think to have healthcare professionals who are properly upskilled, diabetes services to actually have mental health treatment embedded as part of their training, and to be able to support people with diabetes not just with their physical health but also their mental health. Really close blended services between diabetes and eating disorder services, and I think proper prevention programs. So as Sarah was saying, it's so important to think about our language and think about people's experience when they're first diagnosed, and to understand the journey, like how those early experiences affect people down the line. And so to have really robust, like really wholesome, really like holistic, good services when people are diagnosed, so that they have a lot of support, so that they feel really encouraged, so that they have key workers, people that they can reach out to regularly, a familiar face in their team. That's the kind of thing that we want, isn't it? So is there anything else? Anything I've missed, Sarah?
No, I think that was great. I think as Type 1s, we all deserve the very best care available to us. And I really hope that they close this training gap and all this new information filters down to all healthcare professionals, because you know what, we're a great community and we deserve it. We fight every day, don't we, just to stay alive. And you know, I think we're all wonderful people, particularly this community. It's so supportive, and I think we all deserve to have the best care that we can possibly have.
That's wonderfully said. I probably should mention actually that we've been working on some healthcare professional training for type 1 diabetes and eating disorders. So there is actually some e-learning that's going to go out as like CPD accredited, but we do need people with lived experience to help to shape it. So if anybody's interested in helping with that, then please do get involved. You can just message me on Twitter, on X. Yeah, but that will be out hopefully by the end of the year. So that will mean, Sarah, that you can send that to your eating disorder service and say, hey, you need to do this training.
Oh, well, that's great. Thank you guys for giving us your time this evening. I really appreciate it. It's always great to hear about experiences, you know, as professionals and lived experience and coming together, as we've talked about, you know, being really important. Has anybody got any questions they want to ask? Are there any questions in the comments that anyone can see that they'd want to answer, or anyone wants to come up and ask a question in the last couple of minutes? Feel free.
We've had a few comments coming through, and James says, what a fantastic diabetes chat. I wish so many more could listen in. Thank you, Sarah L, for your honesty and being so open of your lived experience. And thank you, Sarah A, for your passionate advocation around Tide. I always think that no one should ever have to do something being asked of them that they feel uncomfortable to do, e.g. being weighed when you guys are discussing that before. So anyone like listening, James is a DSN and a need an educator. So backing up what both Sarah said, really. And then just going on the sort of end of the conversation, which just wraps it up really nicely. James says, all anyone can do is try their best, no more, no less. We all have different levels of 100% each day. I just, yeah, totally agree with everybody he said there. I do hope that you guys have found it really helpful listening in tonight. I just want to thank Hez for the excellent hosting and prepping all tonight, and Sarah L and Sarah A for your lived experience, your knowledge, your expertise, your honesty, like James saying, being open. And I hope that everyone has found it helpful. And please go speak to your team at any point, whether it's to do with Tide or anything else, isn't it? Like the guys have said, no one should be alone in any journey, any walk of life, and whether it's like living with Type 1 or Tide or things. You know what I mean? Please get the support that you need. And I just want to, from my point, just say thanks, Sarah L, Sarah, for coming on and nice chat with us. Thank you.
Thank you.
Yeah, thank you all too. You're all amazing.
Thank you.
One word I learned last week in ISPAD for the DDoC Voices 2024 is it was a phrase that we we said at certain points. We're all gorgeous, and we are all gorgeous people in this community, and supporting each other with this hard condition, right? So we do our best, and that's all we can do. Yeah, thanks again, guys.